I have the pleasure of introducing our speakers today, so I'm going to go ahead and do that. Linda Edwards is a certified alcohol and drug counselor, targeted case management manager, and retention navigator with the Healing Transitions team at Bluegrass Care Navigators. She served Fayette County residents in Wave 1 of the study and currently serves residents of Bourbon and Jessamine counties. She has spent 8 years working in the field of substance use in multiple settings, including residential treatment, MOUD clinics, and community-based programs. She received her master's degree in family studies from Oklahoma State University. Emily Sprouse is a certified social worker and retention navigator with the Healing Transitions team at Bluegrass Care Navigators. She began this position in March 2021, serving Madison County in Wave 1 of the Healing Community Study. Prior to working with Bluegrass Care Navigators, she has spent 10 years working with an interdisciplinary team in the community mental health, MOUD clinics, and residential treatment programs. She received her bachelor's in social work from Warren Wilson College and master's in social work from the University of Kentucky. Candy Brown is a care navigator with the Healing Transitions team at Bluegrass Care Navigators. She previously worked in Boyd County for Wave 1 and is now working with MOUD retention in Carter County. Candy's background is in case management and addiction and recovery, and she is state certified for substance use disorder targeted case management. She received her bachelor's degree from Morehead State University and is currently enrolled in the master's in clinical counseling at University of the Cumberlands. And then lastly, we have Mackenzie Clark. She is the supervisor of the Healing Transitions at Bluegrass Care Navigators. She is a licensed clinical social worker who has practiced in the field of mental health and substance use for the past 10 years. She began her career as a psychiatric social worker at Eastern State Hospital in Lexington, where she earned her clinical licensure in 2017. She has also served as behavioral health case manager, manager of clinical health services, and opioid champion for Aetna Better Health of Kentucky. Mackenzie graduated from the University of Kentucky with a BA in psychology in 2012 and a master's of social work in 2014. So welcome to all our speakers today. All right, I'm going to stop sharing and turn it over to you, Mackenzie.
All right, sorry about that. My screen decided to switch on me. Thanks so much, John, and we are just thrilled to be here with everyone today. Excited to talk with you about quality referrals. So thank you for having us at BCN at KY Open today. So first and foremost, we want to share that Linda, Emily, Candy, and myself do not have any financial disclosures, do not have any financial relationships to disclose. Great. So before we begin our discussion, we want to talk a little bit about the practice gaps and the educational needs that we want to bridge in terms of quality referrals. We know that the individuals that we work with who have opioid use disorder and substance use disorder, they often face barriers to seeking treatment, to seeking sustainable resources, and in turn to improve their recovery capital. As well, we know that the transition between care settings that presents vulnerabilities to people who have substance use disorder, who are seeking resources. And then also we know that many people who have opioid use disorder and in general substance use disorders, they may have a mistrust of their providers. And this may be due to a history of poor quality referrals, or maybe a history of a poor relationship with that provider. So how do we want to bridge these gaps today, and what do we want to learn? We want to talk about and identify the vulnerabilities and the common barriers that the clients that we work with face. We want to identify supportive and high quality referrals for those individuals, explain the importance of thorough, active referrals during times of transition, because we know that this is a very vulnerable time for those who have opioid use disorder and other substance use disorders. And in general, we want to maintain a focus on person-centered care and a person-centered approach from the beginning to the end of the time that we're working with our clients. Right. So we want to first start out by talking about the range of referral opportunities that we have with our clients. We know that the clients that we work with, they often have very complex needs, and many of those needs may go unmet, and that might be because of a lack of knowledge of available resources, or other potential reasons. So through collaboration and with external partners and referrals to other agencies, as care navigators, we can link our clients to those resources. We can allow that person to be treated in a holistic manner, and make sure that they're getting all of the care that they need to reach their recovery capital and improve it. So I'm going to hand it over to Linda. If you don't mind, Linda, to share some potential referral needs that our clients may have, and really what we look at in terms of a range of referral opportunities when we're working with our clients.
Yes, I put together a list of potential referral needs, and this is not intended to be all inclusive, but it is some of the more common types of referrals that we see that are needed by the clients we serve. Mental health agencies, and with mental health agencies, a lot of clients are looking for therapy that is beyond what they get in their substance use disorder treatment, or also for mental health evaluations if they need medication for a diagnosed mental health issue. Health care, dental care, and we know that there are several clinics in this area that serve, that are comprehensive clinics that meet the needs of mental health, health care, and dental care all under the same roof. Some of those would include Bluegrass Community Health Center, Health First Bluegrass, and White House clinics that are located across the state of Kentucky. MOUD providers, resources for recovery meetings such as 12-step, which may include Narcotics Anonymous and Alcoholics Anonymous, also Smart Recovery and Celebrate Recovery groups, self-help groups. For example, if you have a client that may have been court ordered to receive anger management classes, there are lots of others, but that one just comes to mind. Homeless shelters, housing authority offices, which are available in most counties. They assist people with accessing Section 8, the Section 8 list, and also resources for income-based housing. And then food banks and agencies offering free meals in the community. Department for Community-Based Services, or DCBS, for SNAP benefits, health insurance, and child protective services. Child care needs, domestic violence resources, employment or job placement services. A couple of those that I have used on a regular basis are Kentucky Career Center, which has regional offices located across the state. They'll help people with training for jobs, brushing up on resume services and things like that. And then once they get a job, they can help people with uniforms or footwear that they may need for their job. The Goodwill Corporation has a career program that is real well respected. And also, if you're in the Lexington area, Jubilee Jobs is an agency that can help folks with some training and access to jobs. And then vocational rehab, adult education, which provides services such as GED or English language acquisition classes, college and career resources, and churches. We live in an area, of course, that has a lot of churches, and many of them offer different programs and resources to the community.
Thank you, Linda.
Mm-hmm.
It's great to see the large range of opportunity that we have to help our clients with referrals. And like Linda said, this is just a small list of the things that we can help with in terms of referring our clients. Great. So when we first start working with our clients, we like to keep in mind this STAR model for effective referrals. It's really going to encourage us to use a thorough model and make sure that we are covering really all bases when working with our clients. So you'll see here that STAR stands for supportive, thorough, active, and referral quality. So initially, we want to know our role. We want to share our role with our client, and we want to talk to the client about what their role is going to be in terms of facilitating referrals. Again, focusing on a person-centered approach. So we want to support the client's decision in what they are prioritizing as their main goals for what referrals and what resources they are seeking. We want to be thorough as well. We want to come prepared with the correct information and evidence-based information as well. We want to be knowledgeable about the resources that we're providing and the referrals that we're making for our clients. And being active too is really important. We want to be alongside the client throughout this process as much as they would like us to. So referral quality. Lastly, we want to follow up. We don't want to just provide those referrals and say, good luck, here you go. I'll see you at another time. We want to set up that time to follow up with that person and have note that we want to talk specifically about those referrals that we've made previously. And we can become even better experts if we keep note of those referrals that were really helpful. And that can only help our other clients in the future too. Okay, another common model and approach to referrals that you may be familiar with, or maybe you are practicing this and you don't even realize it, but that's SBIRT. So it stands for Screening, Brief Intervention, and Referral to Treatment. So we want to screen quickly because we know that our clients, we may have limited time to work with them. So we are providing a quick screening when we first meet with that client. We want to determine the severity of their substance use, particularly their opioid use disorder. That helps us to determine what level of care is appropriate. And we can then talk with their providers about their thoughts about the level of care being appropriate as well. Brief intervention. So we are going to focus on increasing insight and awareness of that client's motivation towards change. So you may hear a lot of things throughout the time that we're with you today about how we really try to use motivational interviewing to determine what is that client's priority and what is their motivation looking like towards behavior change. And then lastly, referral. So having those referral opportunities readily available for that client to quickly provide those resources and help them get the care that they need. Here are some examples of SBIRT that may look familiar to you. So at our initial meeting, we're going to screen for not just opioid use disorder and other substance use disorders, but what mental health conditions do our clients have? Access to housing, to food, to transportation, those social determinants of health that are so important to helping them get to treatment. Again, using motivational interviewing throughout the process of working with our clients, and then positively reinforcing the small and the big steps that they've made towards positive change. And that really helps our clients to keep going and to reach their recovery capital. So if you want to learn more about SBIRT, there's some resources about it on SAMHSA's website. We just placed a photo there for you so you can see where to find those. All right. So the clients that we serve, they are often in a vulnerable state due to barriers to care, history of trauma, potentially they had past negative experiences with healthcare professionals. So let's have a discussion about how we as care navigators initiate meaningful conversations with our clients. And how does this allow for connection to strong referrals? Linda, we will start with you if you want to tell us a little bit about how you approach this.
I try to work with my clients from a person-centered perspective, acknowledging to them that they have the right to make informed decisions about their care, about their treatment. My goal is to treat clients always with dignity and respect while offering support as needed. I'm in a partnership with the client, and I want them to know that we are in a partnership together. However, I think it's important for them to be able to lead the process, knowing what's best for them, and I'm in a supportive role. Many of our clients have a feeling of being judged and stigmatized, and rightfully so, because we know just historically that people with substance use disorders are treated badly in some venues, and also it's you can get on social media and see people making rude comments and et cetera about people who have substance use disorders. So we want to try to work with our clients to let them know that we don't feel that way about you, and we're going to treat you with respect, the respect and dignity that you deserve. I think that being judged and stigmatized creates shame and feelings of hopelessness that they may never be able to escape their past, feelings of isolation. And again, just those labels of unflattering words such as addict or junkie that we don't use from a professional standpoint, but there are a lot of people in the community that do use those terms. So as a worker, I think it's our responsibility to talk with the client and understand what their bad experiences are and the things that may trigger them to have a reaction when they're working with us. Acknowledging that you understand what they've been through, but you don't really understand how they feel. I think it's a kind of a fine line there, because you don't want to give the impression that you are in the same position unless you are. And, you know, some people, peer support specialists and such, may have had some more personal experience than what some of us care navigators have had. But again, just a willingness to listen and affirm your clients without being judgmental is critical.
Thanks, Linda. Those are all really important things to keep in mind, especially when building that rapport with our clients. So Candy, if you don't mind, could you share a little bit about how you come prepared to talk about gaps in care with your clients?
Hi, yes. To piggyback off of Linda, I remember the first time that one of my clients that I met with said, addicts get sick too. And that stuck with me so deeply, because it was when I was asking him, when was the last time that you saw a medical provider? And his experience had been one that he went and immediately, it was something completely unrelated to his substance use disorder, yet he felt they were judging him. And it was at that point I decided to start making my own list. I started calling facilities, making my list of MOUD friendly providers, people that were going to treat my clients with respect and encourage them to come back, encourage them to take care of themselves. So I'm always prepared with those phone numbers, those contacts. I don't want to send anyone anywhere that they feel like they're not welcome. I always have our HCS resource guide per county. BCN, of course, has wonderful resources for us to provide. It's just about making sure that that person knows that their health does matter. It matters to me. I care. I'll be that person that cares now, that will encourage you. We work through a process of putting my phone number in their phone while they're with me, so that they can reach out if they have any problems getting in contact with the provider that I'll possibly refer to them. And we'll also put phone numbers in their phone at that time of those providers if we need to do that as well. And I like to follow up. I want to make sure that experience and that appointment, make sure that they attended, but make sure that they were treated with respect, treated well, and that they felt heard while they were there. Otherwise, we'll need to find another provider, because no one's going to continue to see a provider if they don't feel those way. They don't feel heard, they don't feel important, and they are. So I just like to be prepared with anything I need from the first day I meet someone to send them to the best possible providers.
Excellent. Thanks, Candy. Appreciate you sharing all of those tips. All right, Emily, if you want to talk a little bit about how you follow through with with referrals with your clients, and how does that impact the conversations about their gaps in care?
Absolutely. So early on when I started with Bluegrass Care Navigators, one of the first things we were taught to do is go into every visit with the client and say, what is most important to you today? Obviously, across the service lines, we have our overall care plan and kind of things that we're working on, but trying to focus on the day and now of what are their biggest concerns. And so once we recognize that, kind of exploring what has worked well, kind of building off what Candy said, what's worked well with providers in the past. Are there things that they don't want to see or they don't like the way they were treated at a certain place? And then we kind of make a list of questions they have, concerns they have, and determine what kind of provider they need to be seeing for that appropriate concern. And that's when we kind of, I know everybody hates to role play, but being able to kind of have that dialogue with them before we actually make the call or request that appointment. So kind of asking them the process of going through of what questions to be prepared for, having their insurance card with them, and like making sure like they write down who their appointment is scheduled with, the day and time, anything they need to bring within that day. So then I'll be with them alongside them as we do in real time, make that phone call to schedule that first visit. And then after that's done, we'll also kind of look at what does follow-up care look like for canceling that appointment, or who do they need to contact if they need to reschedule it, and just kind of build off that, and definitely using motivational interviewing to explore any resistance they have, and definitely just want to move forward with positive change for them.
Excellent. Thanks so much, Emily. I think those are all really great considerations when we are talking about gaps in care, and are really, really helpful tips. All right, so we've talked about how transitions with our clients can be really difficult, and we know that thorough and referrals are just as important during that time. Clients that we work with, they are at high risk, especially at those times of transition. So high risk of return to use, and most importantly, high risk for overdose death. So we want to talk a little bit about what important steps we focus on during the referral process for someone who is receiving treatment for opioid use disorder. So we will start with you, Candy, if you want to lead us in this discussion and give us some advice for what you consider when your clients are entering periods of transition.
Sure. I work with a lot of clients who come to the realization that they need possibly a higher level of care. Many of my clients are currently homeless and in very little outside support. In those moments, that's where I feel my role becomes the most important, because if someone decides they want that higher level of care, the last thing that I'm going to do is give them some phone numbers and send them on their way. I'll keep them with me. I'll be their support. I'll hold their hand. I'll make those phone calls with them. And oftentimes I will arrange transportation from a higher level facility, such as a residential treatment facility, to pick them up at my office. That gives them the ability to sit, be comfortable. Absolutely, I'll assess what symptoms am I seeing? Am I seeing that they're in active withdrawal? When was the last time they ate anything? Do I need to get them something to drink? These are all things that are important, because I do want them to be comfortable and confident in their decision. It's a big decision, and I don't want them to be alone. I don't want them to be back outside, back on the street, and have that moment of, run away. So stay with me. We'll talk it through. I'll be supportive in that time period. Again, I'll make sure that there's been several times that we've called a residential together. And of course, the residential will have to do an assessment with that client personally, but I can be there to be their support support system again. A lot of times they'll look to me, what do you think? What do you think? And it's their choice, their decision. They just need that little bit of encouragement. So I'm happy to be that for them.
Great, thanks so much, Candy. And this is a time where we really rely heavily too on our communication with the interdisciplinary team too. So our treatment providers at the MOUD clinics where our clients are attending treatment, as long as we have that ROI completed, really working together with the client to determine what level of care they really they need to support their recovery. Thanks for sharing.
I'm fortunate too, because the clinics that I work at, they come together as a team to support each of those clients. I love to see that. You know, if I need medical, I can immediately go get medical, bring them in. Those are the things that I do look for when I'm working with my MOUD clients.
Great, thank you. Great, Emily, if you would touch on how you, what considerations you make during periods of transitions, especially in terms of the types of resources and how you present those resources to your clients.
Absolutely. So I think we all have phones in our hand. We all have, most of us have access to computers and things like that. So anybody can kind of do a general Google search of doctors near me or what have you. But I think we as care navigators are really good about kind of knowing who locally provides quality care, whatever that care service may be. So one of the things I do with clients is having a little printed off kind of screenshot of websites. So this visual has White House Clinic. So on the website, you can kind of see it goes down of what services they provide. It also has the locations with the address and contact information. And here at the top, I've circled the phone number. So they need to call to make an appointment or for any questions they have. Or if they're not comfortable with making that phone call, they can always go onto the website and know where to go to request an appointment online. So just having this with them, either on a piece of paper or taking a picture of it with their phone, just to have that resource to refer back to. And then I think something that we often don't think about is utilizing pharmacies for assistance. So you leave a doctor's office, have a prescription for a new medication, and they're going to ask you, well, what pharmacy do you want me to send this to? And you're kind of, I don't know who's best to go to. I don't know who accepts it. So that's kind of where we can come in and have a general knowledge of local pharmacies that treat folks with respect, whatever their concern may be. But when folks first reach out to a pharmacy, make sure like they know what their hours are, if they have their medication in stock, or if it's something that they need to go ahead and order ahead of time. Some folks may have difficulty with transportation with getting to the pharmacy. So asking if the pharmacy can deliver or do some sort of pickup service. And then like a lot of things these days, medications are expensive. So using resources like GoodRx or different savings plans to reduce the cost of medication and make it affordable. And then kind of going back and forth with the pharmacist and the insurance company is a lengthy thing. So no one communicate with your doctor of saying, hey, can I have the generic form of the medication? Would you recommend that? Or can we look and see if there's a prior authorization that's needed for this medication? And then looking at kind of those bigger picture ideas of just getting to different appointments is using a great resource to use is if the client has Medicaid, using Medicaid transportation, also known as federated, or like looking through, again, printing out the sheet for folks and kind of saying, okay, you're going to need to know your Medicaid ID number or your social security card for that first time that you call them. And every reoccurring time you call to schedule an appointment after that. And knowing exactly, again, writing it down ahead of time always helps. If knowing the address for your doctor's office, the day and time you need to be there, and writing down whenever you schedule that ride, they'll give you a confirmation number. Writing that down, making sure you're prepared, but also just exploring some other forms of getting to and from appointments. Some larger areas may have bus services or cabs, Ubers, Lyfts, that sort of thing, but some folks may need to use getting a ride from a friend or a family. And something I always try and check with folks if they are driving themselves is to make sure they have a valid driver's license. And if they don't, we can kind of link back to that and get that taken care of for them as soon as possible to make sure they are on the road safely and legally. But I think too, looking at a lot of folks don't know extra benefits that you get with various insurance plans. So kind of referring back to this and knowing, okay, you have an individual that needs glasses. Some insurance plans may offer that, some may not. So making sure that they have the plan that best meets their needs and knowing when open enrollment time is to be able to call and change if that's necessary. And just looking at if some insurance plans offer like housing assistance and they may have a care manager with that insurance. So knowing how to call member services on the back of your card to ask about, okay, I see I can utilize my insurance benefits to obtain a state ID. What does that process look like? So helping them alongside, being with them as like they make that phone call, or kind of encouraging them along the way to utilize those resources.
Thank you so much, Emily. And as you all can tell, there's so many different layers to the referral process and to care navigation, working with a client. And it comes with a lot of experience and just, learning these resources. So that's kind of our tip to you is just keep track of those really helpful resources. And that's just gonna help you and your clients in the future. So these are great things to consider during transition time. And Linda, if you could speak a little bit about how you work with your clients to show them these common websites that are going to be helpful to their recovery.
Yeah, sure. There's so much information that's available out on the internet, and some of it is really high quality and sometimes it's not so good. I don't know if anyone has ever fallen prey to this kind of situation. I have personally in looking for treatment for a family member. You call what you think is a number for a clinic or a residential treatment program, and it's really someone who's trying to get your information so they can have lots of other people give you calls, and they're really not trying to help you find facilities or treatment at all. So I caution you to, stick with those websites that are .gov or .org and such. But when I'm working with my clients, many of them are not very savvy about how to do things on a computer, and some of them probably know a whole lot more about it than I do. But when they're in periods of transition and possibly looking to transition to a different level of care, or maybe a new clinic, maybe transportation has gotten to be such an issue for them that they're trying to find a clinic that's a little bit closer to their home. So a resource that I like to use that I think is very helpful, it's a state of Kentucky government website that's called Kentucky Office of Drug Control Policy. And if you go to that website, there is a drop-down menu for a treatment finder. So if you click on that link, it will take you to a wide variety of different resources. And I'll just name a few of them. And many of you will already be familiar with these, but websites such as Find Help Now, KY, Operation Unite, Kentucky State Police Angel Initiative, GetHelpLex.org, Recovery Kentucky, which is funded by the Kentucky Housing Corporation. Let's see, Substance Abuse and Mental Health Services Administration, which is the long name for what we refer to as SAMHSA. And so most of these websites will have not only treatment finders that you can go in and add filters for exactly the kind of treatment that you're looking for. Some of them will have a real-time listing of availability. And then others offer really good resources for people who are professionals working in this field, where you can find information about different types of treatment, such as, partial hospitalization, day treatment, intensive outpatient There's lots of different kinds of treatment, and your client may not be familiar with all the different options that are available to them. A lot of folks don't find it convenient to go to residential treatment because maybe they have small children and they don't want to lose their job, or certainly don't want to lose custody of their children. So an intensive outpatient program might be a good option for them. But holding their hand when they're not very confident about how to navigate these kinds of resources, but also teaching them so that they can do it on their own. And making, for me, I try to make my office and my computer available to them so that it's not always convenient for them to go to the library or to find a friend or someone that will let them use their computer. So I'm always open to helping, or just sitting alongside while my clients come into my office and use my computer. Something else, and this is just a small thing, but if you, for example, they choose a clinic that maybe they want to try, but they're not familiar with the location of it, you can enter the name of anything on Google Maps and it will bring up a picture, and they can actually see a picture of the clinic, see what that looks like, so they know what to look for. And sometimes you can find pictures of therapists and physicians and such on the internet, and all of those things are just another layer of reducing stress for the client.
Great. Thanks so much, Linda.
Mhm.
Yeah, it really comes back to making sure our clients feel comfortable and confident in their recovery journey. That's one of our main goals. So appreciate you sharing that. We also spoke a little bit about a huge factor during transition from incarceration. So this is a very critical time during some of our clients' lives, and they are at huge risk for overdose death. So we wanted to just share with you a couple studies that looked at this transition period, and this one in particular was really interesting. It was completed in North Carolina, and they looked at the general population versus those who were recently incarcerated, looked at a 2-week post-release period and then a 1-year post-release period. And you'll see here that recently incarcerated people, they are over 40 times more likely to die from an opioid-related overdose death. So just really kind of alarming number. I know it's probably not a huge surprise to a lot of us working for the Healing Community Study, but it just kind of goes to show the work that we are doing, especially in the criminal legal system, in terms of linking our clients to MOUD at that time of release, and not just to MOUD, but other resources too. So we've talked about other social determinants of health. Those can be just as important as getting that first appointment at the MOUD clinic. So they can't get to that appointment without transportation, potentially without some sort of income, or especially without some sort of insurance. So that's where we really come in to play as care navigators and as people who can help our clients seek resources and referrals. And this was interesting too from the study. In quotes here, it says that within the first 2 weeks after release, the risk of death from drug overdose is 12.7 times higher than the general population, with that risk of death being further elevated among females. Another article that we found was an interesting study that looked at post-incarceration fatal overdoses after implementing medication for addiction treatment. And this was in a statewide correctional system. So in 2016, 26 of 179 individuals who died of an overdose were recently incarcerated, compared to 9 of 157 individuals in 2017. So that represented, among those people, that represented a 60.5% reduction in mortality. So just gets us really excited about the work that we are doing right now with the Healing Community Study, and makes us hopeful for the outcomes from what we are doing will hopefully show that that we are saving people's lives with the referrals that we provide, especially during these critical times of transition. I'd like to pause here if anyone has any questions, if anyone wants to just share any kind of examples that they've had in working with clients, or maybe in personal experience if you're inclined. We'd love to hear from you all. If you have any questions or comments, feel free to come off mute or put them in the chat.
Looks like Kristen has her hand raised.
Yeah, go for it.
Yeah, I just had a quick question. I was trying to write down some of the statistics that you were giving from that previous slide. If you wouldn't mind to readdress the number with women, because you made a difference between the number of deaths among female population.
Yeah, so this graph right here, Kristen, doesn't specifically state the statistic for women. It just, in the study, it did share with us, and it's in quotes here, that the risk of death was further elevated among females. So in the references slide at the very end, you'll find the link to this article. So they would likely have that information in there. I don't have it on this slide right here what the exact statistic was for women, though. This is the graph here shows both men and women. Does anyone have any thoughts, though, on why that might be the case?
Jessica, did you have a question? It looks like you have your hand raised.
It's me and Jessica, it's Shirley. I have a question for you guys. First of all, thank you. There's a load of resources in here. I didn't realize that you guys did all this stuff. We will be here at the Boyd County Detention Center. They're going to start an MOUD program here. The struggle we have is being able to afford Vivitrol. We don't have a provider, and the cost of it that the provider was charging us was astronomical. It was $1,600 a shot. So if there's any way we can link up, or you know of any resources that may be able to help pay for that, because once they're incarcerated, Medicaid no longer covers anything. So we're kind of struggling with that kind of piece of the puzzle to it. Thank you.
That's really exciting, Shirley. So are you saying that they would be able to receive their Vivitrol injection while they're incarcerated?
I think that's how we're trying to lay it out. And before, like if people come in here and they were already on MOUD, they would not receive it after they got here. So that, as well as I do, that's severe withdrawal. But there was an ADA lawsuit that went through with the Department of Justice for the Fayette County Detention Center that's kind of nipped that in the bud. So if they come in and they're on it, then we will continue care here. And if they come in and they do take Vivitrol, then we want to be able to provide that. Also, if they're being released and want to do treatment, then we're going to be able to do that as well. The only issue is getting that Vivitrol shot, because a lot of people opt for Vivitrol leaving here, and we've not been able to provide that for a few months now because the cost is just astronomical.
Yeah, absolutely. I think a conversation that we could have with the Medicaid, if they have Medicaid, the MCO, or the insurance provider, is that exact date for when their coverage ends, because a lot of times there is opportunity for, backdating that and retro billing that. It would just be kind of a question to pose to them. And I'm not sure if there's anyone on the call, any of our medical providers, or anyone who might be able to speak to that about potentially if someone's needing something to take similar to the injection for that limited amount of time before they're released.
There's distributors actually that are out there now. I know that they have contracts with, well, I guess it's kind of a pilot program with Bourbon County, with Montgomery County, as well as Round County. So if Boyd County could potentially get a hold of the MTA for Round County and speak to them, they can tell you a little bit more about the program. If you send me a message, I can actually give you the name of the gentleman that provides and the phone number of the gentleman that provides the Vivitrol shots for those programs, and he could probably give you a whole lot more information about it.
Thank you, April. I'm sending you a direct message now. I'm going to send you my email address. If you want to email me or whatever, what you have. Like I said, we have provided that Vivitrol here for a minute, and then the provider started charging us $1,600 a shot, and you know, Medicaid being shut down when they come in, and some people have been here for months. I'm happy to see this happening, and here's why. We've had in the last 90 days, we've had 7 people leave here and die within 48 to 72 hours of leaving the detention center. You know, its tolerance is down, and they return to use and they die. So I think I'm excited about this. This is like something that's huge here, and being able to provide this for our participants is everything. So
Mackenzie, I would just add one quick remark. I have a professional relationship with a pharmacist that works in Jessamine County, and I know that he goes into the jail and also to some residential programs in the Jessamine County area, and he does give Vivitrol shots. So I can, between now and next week when we have our Q&A session, I can reach out to him and see if he knows of any resources for grant funding, or, you know, any distributors that give discounts or anything like that. But I don't know off the top of my head, but I will reach out to him and see if I can find out anything before next week.
thank you, Linda.
You're
We have
welcome.
everything in place here to get it done. We have the mental health part of it now. And the way that Jailer Hensley wants to set it up, we're set up for that. We've got the medical, we've got the mental health, 2 recovery coaches. So we've been asked to do like the substance abuse classes with them. So everything's set up.
That's really exciting. And
That's
we
great.
appreciate bringing that up, Shirley. I think we definitely can follow up on that next week. And we would love to collaborate with you on that with any resources that we know of too. So feel free to reach out to me, and I can connect you to any of the navigators who may have some helpful knowledge on that or resources. And I see Alyssa in the chat also mentioned that there may be an opportunity for oral naltrexone if they're on naltrexone. I am. So also another possibility. Very exciting. Okay, so all of us know that barriers, there are so many barriers to medication for opioid use disorder, especially in rural areas. This is a big problem for us in Kentucky. And we are living through that right now through the Healing Community Study, working in several rural areas. So I'm going to hand it over to Linda to give her expertise and what she's learned about helping clients kind of bridge those gaps when they live in rural areas.
Well, one of the biggest barriers is the actual availability of treatment facilities. Rural communities often lack treatment facilities that offer MOUD treatment, requiring patients to travel further to access the treatment that they need. And I think this is especially true for individuals who are using methadone treatment, because that requires daily dosing. I used to work in a methadone clinic some years ago, and we had folks who drove 2 hours one way to come to the methadone clinic every day to dose, because there wasn't one closer, and they did live in a rural area. So methadone treatment requires a little bit different need in terms of access to the facility, and that's a real barrier for some people. Another barrier is transportation. Many rural residents face transportation barriers, including no driver's license, no access to a vehicle. And as we already know, the shortage of public transportation in rural areas, and also the high cost of gasoline. So it could be that someone has a car, but they don't have a job, so they can't afford to put gas in their car to get to and from. So these barriers of no transportation can jeopardize follow-up visits and adherence to treatment. And what sometimes happens is, they try to find a ride with a friend, but that's not always reliable. So their attendance can be spotty, which, can result in them getting kicked out of treatment. In a situation where a client has very limited transportation, but they do maybe have access to technology, or have a smartphone or what have you. As a care navigator, we can help them access resources for telehealth treatment, which, we have more resources for telehealth than we used to, maybe not quite as much as we did during COVID, but there are some of those out there. So it's good to be aware of which clinics or online programs you can link clients to if they don't have transportation. Another barrier is stigma, and patients may not, is in small communities in particular, may not seek treatment out of fear of losing their job because everybody knows everybody's business in a small town. Jeopardizing relationships with friends and family who may not be supportive of MOUD, or also they may just be embarrassed for other people in the community to know that their family member has a problem. Or members of the community finding out, maybe people don't want their children's school to know that they are in MOUD treatment. I had a client one time that mentioned to me that she didn't want anyone to know because she was afraid that DCBS would become involved and she would lose custody of her children for being in MOUD treatment. And so those fears are real, and they're enhanced in small communities where everyone knows everyone. And then just technology in general, both patients and providers may lack the technology needed to access the internet. Some may have access, but it doesn't work in a timely manner like it should. And also a lack of devices such as laptops or cell phones. And I would point out here that, and most of you already know this, that there are some programs where case managers and care navigators and other helpers, peer support specialists, can help clients obtain cell phones. And so that would give them an opportunity to at least have access to a phone where they could call and possibly use telehealth technology. So those are some of the barriers, some of the top barriers that we've seen that people face in rural areas.
Great, thanks, Linda. Really just kind of hinders our clients and us for getting them the right care that they need and deserve. What barriers have you all come across with your clients or personally that you've seen to seeking MOUD treatment or really any type of treatment in our state, in our rural areas? Feel free to put anything in the chat, or if you want to come off mute and speak to it, we're happy to take questions or comments. We will move.
I work in the Fayette County area, and here you all have access to the bus, but coming from a rural area, we don't have that back home. But one thing I did learn about was maybe the BG Cat bus. And they are starting to go to some of the rural counties that could help clients in the future too.
That's really good to know, Brandy. Thanks for sharing. So many people are putting in the chat that transportation is an issue. Yeah, I mean, we've said Madison County when we worked there, it seems to be a transportation desert. Other people have said mental health. Absolutely. If someone is in crisis, or maybe they just aren't in a stable place, they may not be able to get to treatment. Trauma Most definitely. So that, like we talked about the past experiences with providers, if someone has a bad taste in their mouth for a psychiatrist that they saw 5 years ago and they say, I'm not going back to a psychiatrist, that really can affect people's ability to get to those providers. Thanks for sharing.
Mackenzie, one other just quick point that I would say is that sometimes people who live in rural communities will, if they have the ability for transportation, they will travel to areas outside of their community where they live, just so out of fear that people that work in the clinic may actually also talk about their business too. So that can be an issue in a small community.
Most definitely. And we hope that those clients can get to the other counties financially. But it doesn't always happen, and that can be a barrier in and of itself to staying in MOUD treatment too. We know people who have driven 2 hours one way to get to the clinic that they want to go to, and we keep that in mind and we respect that because we follow a person-centered approach. But again, keep in mind that can be a barrier to their continued success and recovery. Right. So engagement with our clients really starts at the very beginning, and it keeps going through the whole time that we work with them as care navigators. But we all know that it can be time limited. So we have short periods of time usually to make a big difference and to get that client to engage if they're willing and they want to. So we'll talk a little bit about how we provide efficient linkage to resources and referrals, and how, while we do that, how do we demonstrate kindness while working alongside our clients. Candy, I'd like to start with you, if you don't mind speaking about how you start to build that rapport and that trusting relationship.
When I receive a referral, or even if someone comes in on their very first day to come into treatment, if I'm able to meet that person face to face on that day, that's what I attempt to do. If not, I encourage the client to meet with me face to face within that week. The reason for that is I don't want to be a voice on the phone. I want them to see that I'm a person like them and that they've got someone actually working with them. I know with the past few years where we've had COVID, telehealth has taken off and been a very big thing, but you can never have that personal trust and connection that you can build face to face with someone. SAMHSA had put out a reviewed article a couple of years ago, even stating that people tend to be more honest and open when they're with you, when they're in person. It's so much easier to hide behind a computer, hide behind a survey online. Whereas, yeah, talking to somebody in person, you can't beat that. And people end up seeking me out because of that, because they know that I'm willing to work with them face to face. If I need to come to where they are, if I've got someone staying in a hotel and need to do a hotel check on them, I'm more than happy to go and knock on that door, because I want them to know someone's here and someone's working with you. However, in the same thing, you've got to set those goals from the beginning. Here's what I can do towards your plan. What can you do towards your plan? So that way that they know that this is theirs, and the work that they put forward is, it'll be rewarded. So always develop that partnership right in the beginning about who's going to do what towards their goals. These are always their goals. I typically start in the referral process day one, going through a questionnaire. If someone says that they don't remember the last time they went to the dentist, let's address that right now. I don't want to go back to it. Let's address it now. I've got dental providers that I know will work with your insurance. So let's work towards scheduling an appointment and following up with that. Again, because it's best to address something immediately. And I have a lot of success with doing that. People know that they can trust me, that they can call me if they're having problems with reaching a provider and whatnot. And they know that they are welcome to come in when I'm in the office. That I celebrate every progress. even someone saying, hey, I didn't use a syringe for the past 2 weeks. I did use methamphetamine, but I didn't use a syringe. I do celebrate that with them because that is progress. Okay, so where are we going to work now? What's our next goal with reducing use? And they like to report those things. It's a success to the person, it's a success to me, and we celebrate everything.
Thanks so much, Candy. And our team of care navigators, we put together a care plan with each of our clients. And we have open discussions with them about that. You know, this is their care plan, and we're just kind of there to help facilitate it and to help, you know, give suggestions and professional advice, but it's their care plan. So we have those conversations with our clients about what do they expect to get out of the work that they do with us, and what can we do to help them reach those goals. So Emily, when you work with a client and you're trying to facilitate and encourage engagement, what are some of what would you say is kind of the best thing to model and to focus on?
Yeah, so kind of building off what you said with the care plan stuff, just spending like that first time doing the assessment and the biopsychosocial is getting to know that person. I mean, we go through a laundry list of questions, just trying to know what barriers they have or just their demographics. But from then on, kind of working with them to create a care plan that works for them, and keeping in mind, like, we are here to help advocate for them, empower them, let them know that they are in control of their treatment, and we are here to support them improve health, well-being, and long-term recovery. And knowing the services we provide are we're voluntary, we don't bill for insurance, there's no demands. We just want to help folks have that independence in the long run, and recognizing that they are more than a disease, more than a diagnosis, and definitely treating them with dignity and respect.
Great. Thank you so much. Two very, very important things to keep in mind, especially because we, as care navigators, we may not have lived experience with opioid use disorder. We don't have that superpower of knowing having similarities to what that client is going through, like some of our friends that we work with. So we really want to model that behavior and that approach. All right. And Linda, if you don't mind to round us out and talk a little bit about your process for helping clients stay engaged after referral and admission.
Sure. I think using a strengths-based approach with clients is really helpful to them. I believe a lot of clients that we work with haven't spent very much time thinking about what they're good at or feeling like they're good at anything in particular, and suffer from very low self-esteem just from years of making bad choices and feeling like they've disappointed or let people in their lives down. So to help build them up, to help them identify what they're good at or what they'd like to work on being good at, can increase their competence and empower them as they work through their substance use disorder and their treatment for it. Again, I think it's just so critical to their confidence if you can find something, as you know, they see you as a professional person. If you can find something and bring it up to them, you know, you don't have to go overboard and give them a gold star on their chart and stuff like that. But you know, just being very genuine in your remarks about something that you've noticed about them. Something that really always impresses me when working here, well, I guess I probably hadn't said this, but I'm placed in a methadone clinic. And so a lot of the clients that I work with are here every single day. And a lot of them come before they go to work in the morning. And when I think about having to do that myself, I really think, you know, that it takes a lot of determination to get up out of bed every morning. And some of them even ride the bus. So that takes a real commitment to improving your quality of life and yourself. And so I always like to point out to clients that it impresses me that they're committed to their recovery and they're getting here, whatever means it takes, that they are getting here. Had a gentleman that I worked with in wave one who had some physical limitations, and yet he walked here every day. He never missed. And he was kind of one of those people in the clinic that he knew everything about everybody that's a patient here in the clinic. He was kind of like the social committee here at the clinic. And I commented to him one day that he sure was good with, other people and talking to other people. I might also add that he also went to a 12-step meeting every single day. And I said, you really seem to be good at talking with other people. And he said, well, yeah, I like to help people. And I asked him if he had ever thought about being certified to be a peer support specialist. And he just kind of looked at me, and his eyes welled up. He said, nobody has ever asked me if I would be interested in doing anything like that. He said, that would be like a career. And I said, yeah, it would. And so I shared with him some information about how he could get started. I'm no longer working with him because that was wave one, but just looking for those things that stand out to you, that your client is going above and beyond. And we know that not all clients, it's hard sometimes to find something good and something positive, but if you can and share that back with the client, it really, really does build their confidence. Let's see here. Yeah, that's about all I had about that topic. But I just a sidebar that I had made myself a note to mention this as well is just with regard to engaging clients in the referral process. If you work in a facility where they give you permission to meet your clients outside of the clinic or whatever your agency is, that can be a real invaluable tool when you have clients that work crazy schedules or maybe do like transportation. If you can set up a time to meet with them in unusual places, maybe, obviously safe places, but maybe in a park, maybe at McDonald's and have a Coke. Or I have met with clients during wave two at the Walmart parking lot, just because it was easier for them and they were on their way home from work. So we will hand off paperwork or just sit and talk for a little bit. So thinking outside the box with having, with regard to getting face-to-face with people can sometimes mean doing things out in the community. But if you're allowed to do that in your work, I think it's really invaluable.
Absolutely. Really great things to consider and to remember. Thanks so much. So we'd love to hear from anyone, anyone on the call too. What are ways that you help build confidence for the people that you work with who have opioid use disorder? And how do you do that to help build their recovery capital? Or any examples that you'd love to share with us that have worked really well for you in the past? Active listening, absolutely. There's nothing like just hearing that professional across the way from you just talk the whole time. That it's not productive and it's not engaging. Yeah, Whitney, coffee shops and libraries are her favorite places to meet with clients, as long as the client's okay with being in that public space. Getting them outside the clinic that has been helpful. They're more open and laid back. Definitely. That's kind of our uniqueness about our role that we're fortunate to have with Healing Community Studies. We can go meet people outside of the clinics, and it does a lot for their success in building capital. SMART goals, yeah, simply just telling them how proud you are of them. That goes so far. And I think we all know that kindness can just go a long way too. Even the smallest little gestures and just saying, I'm so happy to see you here today. I'm so glad to see your face, and just see that you're here and with us. Share free resources for peer support trainings. Absolutely. You know, we do so much good for our clients when we can share whatever knowledge that we have. And my participants that I do not see weekly that may live far away, I mail them small note cards with positive affirmations to let them know I care. That's really neat. Oh, that's cool. Whitney said at her new placement, clients are more eager to meet her knowing that we are in partnership with VOH. She said my clients love our VOH PR. Shout out to Megan. Really cool. Again, you know, we don't have that superpower of knowing some of the things that our clients are going through and to an extent understanding what they're going through. So when we can connect someone to our friends at VOH, that goes so far. Okay. So to wrap up, we want to share some examples of high quality and poor quality referrals, and maybe have a little bit of fun together before we end for the day. So we're going to start with Candy, and Candy's going to share with us an example, a real life example, maybe of a poor quality referral and a high quality referral.
Poor quality, absolutely saying, I'm sure if you look in the phone book, I'm sure if you Google, you can find plenty of providers. You just have to call one, find one that takes your insurance, and then schedule an appointment. Things that are small to a lot of us are overwhelming to other people. And it's so important to remember that right there. I mean, that sounds like a huge lot to somebody who is, you know, with anxiety, with problems with transportation. That's a lot of things. So a good quality would be, I understand you don't have a primary care doctor. Travel is difficult. Let me help you contact some providers local to you that will work with your needs, and make sure that it's someone that you're going to be comfortable with. I want my people to be connected with someone that they are comfortable with sharing, number one, that they are on MOUD, that they can address other concerns that perhaps they've neglected for quite some time. I would also love to hear from some of our peers, and I know this could be a part of our question and answer next week. I would love to hear when they were coming out and first starting into recovery, what were some qualities from maybe care managers, case managers that helped you, that worked for you, that maybe we could learn a little something else from?
Feel free to come off mute if you want to share any experiences of poor quality or good referrals, or put it in the chat. You all think on that. We have opportunity to add to it. We're going to move on to Emily's. Emily, if you don't mind to share your poor quality and high quality referral examples.
Yeah, so just telling somebody, hey, here's a list of local doctor's offices. You should call them and just ask them if they're accepting new patients, if they treat the conditions that you're concerned about, if they're supportive of MOUD, and just any other questions you can really think about. Oh, it would also probably be helpful if you check to make sure this contact information is correct. This list is a couple years old and they may have moved or gone out of business or what have you. Oh, also, are they in the town across town from you? You might want to find a way to get there, and drop your kids off somewhere too, because you can't bring those with you. And then an example of a more appropriate referral would sit down with somebody and saying, let's review your intake assessment and make sure all that information is correct, and kind of go off of that, and let's find you an appropriate provider that's here to address your concerns, and really listen to you. You can either fill out an ROI with me, I can send over the list of your current medications and diagnoses, or we can print that off with you to take to your first appointment. Also, I remember you saying you had some difficulty maybe reading or writing. Let's see if the doctor's office is able to mail you your new patient paperwork ahead of time. And we can either fill that out together, or we can call and see if they have somebody at that office that may be able to help you fill that out on your first day. And also, I know we've talked a lot about stuff, like let's just write down a list of questions or concerns you have to bring with you to that first appointment.
Thanks, Emily. When we were putting these thoughts together, we all laughed at this poor quality referral because it truly is that bad. I mean, that would be pretty awful to phrase it that way. Anyone can think of any similar examples that have just caught you off guard? They've been such bad referral opportunities, or anything really along these same lines that are really high quality and really helped you or your clients. Okay, we'll wrap up then with Linda's examples, and we have plenty of time then to go through any examples that y'all can think of.
Okay, so a poor quality referral that it would be really easy to do this with a client. You should be able to do a Google search for income-based housing and find phone numbers to call for information. So of course, there's all kinds of, red flags there that, if a client, what if a client doesn't read? What if a client doesn't have access to a phone? What if a client doesn't really know what they're looking for or all the right questions to ask? So a way that I might reframe that would say something like, I have lists of resources for income-based housing in multiple counties. There are a lot to choose from, and I'm not sure exactly what you're looking for. You might want to read through the list to determine which apartment complexes seem like the best fit and start with calling those if that feels comfortable to you. If you need assistance, just let me know and we can make some calls together from my office. And that just, that just lets the client know that, you're willing to be there as a support person, but if they need you to take more of a leading role in helping them gather some of this information, you're there to help them that way too.
I've got a high quality example, but we have another recovery coach that's on today watching. And when she first came into the job, she took some lists that we had, took the time, called the numbers, and put a list for the whole county together of income-based housing, whether it was on the bus line, things like that, and helpful tips. And then that way, we had the whole list complete, and it wasn't like incorrect numbers, and kind of listed it all, like gave more detail for the like what all that area offered and stuff.
That's amazing. Shout out to that person who's on the call.
Yeah, it's Gina. She's on here today.
Go,
She took
Gina.
the time to do that.
And it does. It takes a long time to get all of that together. And so, like we've talked about, so many resources that we find they can be outdated, and taking that time, it's lengthy in the moment, but then it helps our other team members and our clients, other clients moving forward. That's really cool. All right. Well, we thank you all so much for allowing us to be here to talk with you about high quality referrals. And as always, we're here and available to you if you ever want to collaborate or have any questions. Thanks so much.